So coming on to coronary artery disease, perhaps the most common condition we treat cardiovascularly. We all know there are three main coronary arteries, the left anterior descending, the circumflex, and the right coronary artery. And there can be plaques. Cholesterol is a risk factor for that, smoking, genetic factors. Most of these patients with coronary disease with angina, we can treat medically with antiplatelets, aspirin, clopidogrel, ticagrelor. We can give them nitrates or calcium antagonists or trimetazidine to improve their symptoms. We can give them beta blockers or ACE inhibitors to improve their survival. We can control their cholesterol levels. So the vast majority are treated like this, and they're all right. But if they have persistent symptoms, then we can consider stenting. And if they are if they have multi-vessel coronary artery disease, then we can consider bypass surgery. So coronary stents are the best treatment for those who have an acute coronary syndrome. If you have a myocardial infarction, ongoing chest pain, then stenting is the best treatment. And in those with single or double vessel coronary artery disease, which are not controlled with medical treatment. But in multi-vessel disease, then it's better to do bypass surgery, and this involves taking artery from under the chest wall, the internal mammary artery, and more conduits either from the arm, the radial artery, or the saphenous vein. So this is a 68-year-old man. He complained of intermittent shortness of breath and chest discomfort, and you can see he had multiple lesions, one in the left main stem, one in the circumflex, one in the intermediate, and multiple lesions in the right coronary artery. So he went for bypass surgery. This is another patient who had bypass surgery. This is a vein graft in the diagonal artery, and this is the left anterior descending, which had been opened, and this is the internal thoracic artery, which will be sutured to the left anterior descending artery. And the reason why bypass is recommended in this group of patients is that they have a better survival. So this from the Syntax trial, you can see this is the probability of death. The red line is those who had stents, percutaneous coronary intervention. The blue line is those who had bypass. So the probability of death is higher in those who have stents compared to bypass surgery over 10 years. And this is another study. This is the a systematic review of all the randomized trials. The lines in red, those who have stents. The line in blue, those who have bypass. This is cumulative mortality. So mortality is much higher at 5 years in those who have stents compared to bypass. These are in those with multi-vessel coronary artery disease. And the reason that is the case is because the treatment is different. Stents treat the culprit lesion, they restore blood flow, but it does not protect against future lesions which may occur proximal or distal to the stents. Whereas bypass surgery bypass the at-risk region. So even if new lesions develop, it doesn't matter because the whole area is bypassed and blood can still reach the heart even if new coronary disease occurs. So this is a 64-year-old man. He had angina on exertion, and you see on the angiogram there is lesions on the right coronary, some on the proximal LAD, and some on the proximal circumflex as well. In this case, he went for stenting. You can see we can achieve very good results with coronary stents. So good flow through the right, good flow to the circumflex, good flow through the LAD. So this was in 2021. A year later, he complained of recurrent angina, and you can see that the stenosis has developed inside the previous stent in the circumflex, and there was some narrowing in the LAD. So new stents were put inside the old stents, so a very good result again, 2022. This year, again, recurrent angina, and you can see the stent at block in the circumflex and tight stenosis in the LAD. And this is the left coronary injection. You can see there is flow, backward retrograde flow through the right. So it suggests that the flow through the left is very low because of this stenosis. So finally, he's gone for bypass surgery. And you can understand from this example why the survival is better with bypass surgery, because this patient was fortunate to have been able to make it to hospital to have another coronary angiogram, but some patients may not be so fortunate, and they may not have survived to, for this restenosis to be diagnosed. This is another example. This patient, you can see, has very diffusely diseased vessels down here. And sometimes during bypass surgery, we actually have to remove all the arteroma, what we call an endotherctomy. You can see that this is all removed from inside the LAD. And after that, you can see a very nice vessel here, very nice coronary artery, where we can graft the internal mammary artery onto. So sometimes we have to actually physically remove the arteroma from the coronary arteries. But fortunately, we don't have to do this most of the times, but if needed, it can be done.